ಪಾಸಿಟಿವ್ ಅಂತ ಬೇಡ. ಹಾ ಇರ್ಲಿ. ಟ್ರೀಟ್ಮೆಂಟ್ ತಗೊಳಕತ್ತಿಯಲ್ಲ ಸಾಕು ಬಿಡು, ಆರಾಮಕ್ಕೆ ಬಿಡು. ಏನ್ ನನ್ನ ಕಡೆಯಿಂದ ಗುಳಿಗೆ ಔಷಧಿ ಏನೋ ಬೇಕಾದ್ರೆ ಹೇಳು. ಯಾರು ನಿಮ್ ಇದ್ರಾಗ? ಓಕೆ ಓಕೆ ಆಯ್ತು. ಓಕೆ, ಗುಡ್ ಲಕ್. ವಿಶ್ ಯು ಸ್ಪೀಡಿ ರಿಕವರಿ. ಓಕೆ ಓಕೆ. ಸಾಕಾಸ್ ಇದೇನು ಲೈಟ್ ಕಡಿಮೆ ಇತ್ತಲ್ಲ? ನಮ್ಮ ಇದ್ರ ಲೈಟ್ ಅನ್ನು ನೋಡಿ, ನಮ್ಮ ಟ್ಯಾಬ್ ನ ಲೈಟ್ ಕಡಿಮೆ ಇದೆ. ಆದ್ರೆ ಈ ಕಡೆ ಯಾರಾದ್ರೂ ನೋಡೋಣ. ಫ್ಲಕ್ಚುಯೇಷನ್ ಆಯ್ತು.
Good evening, sir. Sir. Sir.
Hello.
Sir, light focus ಜಾಸ್ತಿ ಬರ್ತಾ ಇದೆ ಸರ್.
ಲೈಟ್ ಕಡಿಮೆ ಮಾಡ್ತೀನಿ. ಲೈಟ್ ಫೋಕಸ್ ಜಾಸ್ತಿ.
ಅದು ಮೇ ಬಿ ನಿಮ್ಮ ಹಿಂದಿಂದ.
ಈಗ ಇಟ್ಸ್ ಓಕೆ.
ಹಾ ಎಸ್ ಸರ್.
ಕಡಿಮೆ ಆಯ್ತು, ಈಗ ಬಹಳ ಕಡಿಮೆ ಆಯ್ತು.
ನಮಸ್ಕಾರ ಸರ್.
ನಮಸ್ಕಾರ ರೀ. ನಮಸ್ಕಾರ. ನಮಸ್ತೆ.
Shall I check my slides?
Yeah, please.
Yes, ma'am.
Okay. Aita, it's coming?
Coming.
Okay. Seen properly, na? Okay. ಮತ್ತೆ ನಾನು ಕ್ಲೋಸ್ ಮಾಡ್ತೀನಿ. I'll stop share.
Yes, ma'am. Yes, sir. Yes, ma'am.
Light ಹೆಚ್ಚಾಯ್ತು. ಯಾವುದು? ಚಾರ್ಜ್ ಆಯ್ತಾ? ಲೈಟ್ ಹೆಚ್ಚಾಯ್ತು. ಅದು ಎಲ್ಲಿ ವೇರಿಯೇಷನ್? ವೇರಿಯೇಷನ್ ಎಲ್ಲಿಂದ ಬರ್ತದೆ? ಆ ಲೈಟ್ ಅಲ್ಲ. ಚಾರ್ಜ್ ಬೇಡ ಹೆಂಗ್ ಕೊಡೋದು? ಎಷ್ಟೇ ಯಾವಾಗ ಚೇಂಜ್ ಸರಿ. Why there is fluctuation?
Good evening, sir.
Good evening,
Good
sir.
evening. Good
Good
evening.
evening, ma'am.
Good evening.
So, did you check your uploading of the PPT? Yeah.
I have a lovely background.
Sir, is Sajjan sir, is Manjula logged in? Has she logged in?
No, not yet, I think.
Okay. If she comes, then okay. Otherwise, I will only start off and request you to welcome in the
Yeah,
beginning.
Yes.
And then I will introduce Madam, and Madam will speak.
Yeah. Yeah.
And then if Bharati comes, I will invite her to handle the question and answer. And
Yes.
finally, I'll give conclusion, and then finally Durga Prasad will do the vote of thanks. Sir.
Vote of thanks, yes.
No,
Madam, I hope you have met Dr. Sajjan. He is the president of KCOG.
yes. I have met him once, long time back.
Yeah.
Now you can Channa kansade because now you are looking nice. Otherwise,
Madam knows Kannada also. Sajjan sir.
Oh, on, sir. Oh, okay, fine.
but what happens now if I don't speak frequently?
That's right.
Yes.
Adjectives and adverbs I miss out on, but I can understand everything.
Yeah.
So how are you managing with the language there? They're speaking.
It's Hindi. Hindi is accepted here.
Okay.
But actually, Nepali is the main language here. If I can pick up that will be great. But finding it, little bit difficult.
Little difficult.
Let's see.
It's a little bit like Gujarati and Bengali mixed.
Something like Konkani also, my language.
Yeah. So Ramrocha?
Ramrocha, oh, not bad. You know that. How come you know that?
I used to go to Kathmandu several times, I went as examiner and
okay.
and stay there.
Ramrocho, yeah. Mitocho.
So, and it's not difficult to follow, but
Yeah.
when you want to speak, it becomes a little tricky.
Correct.
But for Konkani, what script are you using?
Kannada? No, Konkani is usually, there is no script. We usually use the Hindi script only, Devanagari.
Yeah, so it's like the Marathi.
Same as Marathi.
So you will follow Marathi very easily.
Yeah, I am become Marathi movie fan now. Lots of good Marathi movies on.
Very nice, yeah. In between, we had excellent Marathi movies.
Yeah.
There is another new one which is coming up. Pangarun. Pangarun means blanket. But it's based on a Konkan story, real life story. So watch that. Sir, you are from Hubli? Hello.
Hello, Suchitra. Hello, everyone. Good evening.
Good evening.
Hello, Babita madam.
Hello, hello. Namaste, sir.
Hello, namaste. Namaste.
Good evening, all.
Good evening.
Good evening, Manjula. How are you?
Hello, ma'am. Hello, sir. Sajjan,
Hello.
sir.
Hello.
Hello, Vijay man.
Hello, hello,
Hello,
Manjula.
Suchitra, ma'am. Good evening.
Hello, Manjula. How are you?
Yes, ma'am.
Nice to see
Thank you.
Suchitra
How are
after a
you?
long time.
You're looking
I
totally
know.
different, like a captain.
Manjula, you will start off, the program, and you will. I have written that you read that, no?
Yes, sir. Yes, sir. Norde.
Yeah. You okay? Thank you. Good.
Okay, sir. ಹೇಗಿದೆ ಸರ್ ಅಲ್ಲೆಲ್ಲ ಅಡ್ಮಿಷನ್ಸ್?
Admission ಆಗ್ತಾ ಇದೆ. Post graduations ಎಲ್ಲ. Difficulty in non-clinical subjects. Not many takers. If there are anybody interested in pharmacology, microbiology, you can tell us. Actually, they are very good subjects to those who are interested in joining the medical colleges and research and all. But
R&D.
I don't know. Physiology, biochemistry also. Other all clinical subjects are being taken. That's they are very like going like hotcakes.
Okay. Clinical subjects ಯಾವಾಗಲೂ ಡಿಮ್ಯಾಂಡ್ ಇರುತ್ತಲ್ಲ.
Yeah. OBG was first to go.
Really? What about radiology? Radiology is also very popular, no?
Yeah, radiology is also popular. Radiology, dermatology are popular. We don't have dermatology.
radiology.
We don't have. But radiology, we have DNB, and that is already taken.
I have about 45 minutes, correct?
Yeah. You have 45 minutes. After that, if any questions,
Yeah.
and then we'll conclude. You can take plus minus. It's
Okay.
single speaker, no?
Single
Yeah.
speaker.
Whatever
Correct,
time you
correct.
Arun, you are there, right?
Yes, sir.
And you are ready with the
Yes.
and
Video.
lamp and other things.
Yeah, yes.
Okay.
ಅಲ್ಲ ಬೆಳಿಗ್ಗೆ ಅಂದ್ರು ಯಾರು ಅಡ್ಮಿಷನ್ ಆಗಿದಾರಂತ ನಾನು ಅಷ್ಟು ಗಮನ ಕೊಟ್ಕೊಂಡು ನೋಡ್ಲಿಲ್ಲ.
We have 2 minutes to go. We'll start sharp at 7:30.
Yes.
Start.
Hello, sir. Arun, you can start.
Yes, sir. Kindly mute yourself.
Yeah.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, Arun. Good evening, one and all. I welcome all the delegates and the faculty for today's CPAP program on contemporary management of preeclampsia by a well-known speaker, Dr. Suchitra Pandit, who is the President Guest Hostess of India and past President of FOXI. So I welcome one and all, and I request Dr. Sajan sir, President of KSOGA, to welcome all the delegates and the faculty. Dr. Sajan sir.
Good evening to all. Ellarigu nanna namaskaralu. On behalf of KSOGA and KCOG, the academic wing of KCOG presents continued professional advancement program. Today we are having a very eminent speaker and a past president of FOXI, Dr. Suchitra Pandit Madam. Today she is going to deliver a contemporary management of the preeclampsia. And I welcome Dean of KCOG, Hema Divakar Madam, and Muralidhar Pai sir, Chairman of Academic Wing and KCOG, and Dr. M.G. Hiremat. He is a chief patron of both KSOGA and KCOG, and our own KSOGA team, Bharati Rajshekhar, patron Nagraj, and this Asrana Treasurer, and Donimat, President-elect, Vidya Thobi Madam, and so many of my team. And I wish a grand success in this program. I welcome all, including Abed Company. It has sponsored this program, and also the delegates, the consultants, and all over India, who are all participating. I welcome wholeheartedly. Thank you very much. We extend grand success from the KCOG KSOGA program. Thank you very much. Thank you.
Thank you, sir. I welcome you to this program. Now I request Dr. Muralidhar Pai sir, who is the chairman of KCOG and also Dean of Sikkim Medical Institute of Medical Sciences, Sikkim, to introduce today's guest speaker.
Thank you, Dr. Manjula. Respected President of KSOGA, Dr. Basavaraj Sajan sir, Chief Patron M.G. Hiremat sir, Dean of KCOG, Dr. Hema Divakar, Secretary, Dr. Bharati Rajshekhar, Secretary of KCOG, Dr. Vidya Bhatt, and Treasurer, Dr. Durga Asrana. As you all know, KCOG, Karnataka College of Obstetrics and Gynecology, is the first of its kind state-wise. And we have been very successfully conducting academic programs, and it is on a regular basis. Last year, we started with We Care program for the postgraduates who are going for exams. Then onwards, from June, we started a monthly program called CPAP, that is Continuing Professional Advancement Program for the sake of practitioners. Today is the 9th lecture in the series. And today we have a very eminent speaker, eminent personality also, Dr. Suchitra Pandit. Arun, may I request you to upload the CV of Madam? As has already been introduced by my colleagues, the simple introduction of her is that she has been the past president of Foxy. That says it all. And now she is currently the president of Justosis. And obviously, she would choose to talk on the management of preeclampsia, which is one of the important aspects of that. Apart from that, she's a consultant in the Department of OBGYN at Surya Group of Hospitals, Mumbai. She's a chairperson of AICC RCOG 2007 to 2020, president of ISOPAR, president Organization of Justosis, even including current year, president of Foxy and ICOG 2014 to 15, Foxy representative to AWOFOG, president of Mumbai OBGYN Society, professor and unit chief, LTMMC and LTMG Hospital Sion from 1988 to 2009, a long innings there. PG teacher for 34 years, examiner in all possible exams, including MRCOG exams. He initiated Foxy Justosis Hypertension Disorders in Pregnancy Certificate course, done 105 so far. Conceptualized Foxy Youth Mela for empowering youth, done more than 300 continuing activities, GCPR 8 guidelines in 2014, continuing work for GCPR. She has been secretary Foxy UNICEF Sion. May I request everybody else to please mute, especially when the speaker starts speaking. It's just be conscious about it.
Everybody.
Please mute yourself. The winner of Lord Planets Award UK 2019, FIGO Women's Award 2018, Maharashtra Medical Council Award 2016, Honorary Fellowship in Nepal Society, MOGS, Dr. Desai Award for Excellence, Foxy Korean Award. She also got Best Committee and Publication Award in Foxy, and Durusha and MOGS Ganatra Community Service Award, awarded 35 orations and more than 2,000 guest lectures in India and abroad. So we are really fortunate to have you, Madam, here to speak to all of us on the contemporary management of preeclampsia. Over to you, Madam.
Thank you, Murali sir. Suchitra ma'am,
Yes.
the floor is all yours.
Right. I'm just doing that. Yeah. First of all, thank you very much, Dr. Muralidhar Pai, a friend of long years. And it's wonderful to be able to speak at KSOGA, and particularly in the presence of dignitaries like Dr. Basvaraja Sachin, who is the president of KSOGA, Dr. Hiremat, I'm sure he's around there, the patron of KSOGA, Hema Devakar, the dean, and Bharati Raj Shekhar, as well as Dr. Durgadas Asrana, and friends again, Manjula, Vidya Tobi, as well as Kasturi. And there are so many I know from the Hubli Dharwad side, as well as Belgavi. So it's wonderful to be here. And when Dr. Muralidhar Pai asked me, would you be able to speak? I said, yes, I'll be more than happy. And we were supposed to speak in March, but then I got this opportunity to speak earlier and chose this particular topic. And this is contemporary management of preeclampsia. So I'm going to just start off with the basic changes that have occurred over the years and what we exactly today want to say and what we exactly mean by the So the term pregnancy-induced hypertension is now replaced by a broader term, which is known as hypertensive disorders of pregnancy, that is HDP. And this is perplexing and clinically challenging group of pregnancy complications. And we all know that they contribute to the maternal and perinatal morbidity and mortality, not just in the underdeveloped, but also in the developed countries of the world. And it is only second to PPH as a direct cause of maternal death. And we all today do understand that preeclampsia is a serious multi-organ complication in pregnant women defined by the new onset of hypertension and proteinuria at a gestational week of 20 or after. So if you're looking at the incidence of preeclampsia, well, 10.3%, but then we know that it increases with multipetal pregnancies. So if you're looking at the National Eclampsia Registry, which was established in 2014 by Dr. Sanjay Gupta, it says 1.9% of all the pregnancies. Now, another thing which has been found is, though earlier gold standard for diagnosis of preeclampsia involved BP measurement and determination of protein in urine, but we also have learned that the preeclampsia complications occur before proteinuria becomes significant. So the current guidelines support the diagnosis of preeclampsia on the basis of hypertension and signs of maternal organs dysfunction other than proteinuria. So there can be preeclampsia without proteinuria, mind you. And because of the syndromic nature and varying clinical presentations of preeclampsia phenotypes, the specificity and reliability assessments to predict.
Sir, moving slides are not.
They're not moving? Are they
not moving?
Slides are not moving?
No, ma'am.
No, slides
ma'am.
are not moving. It's not
Okay.
yet
Slides are
in
not
presentation mode. Only
Okay.
that introductory slide is displayed.
Okay, let me just go back
Only
and let
that
me just. I'll stop share.
slide is there.
I'll stop share and I'll share screen again.
Yes, that
Okay.
would work.
Yeah. Tell me, is this okay? Is this better?
No, Dr. Suchitra, what you have to do is you have
Yes.
to go for the slideshow. Then only the slideshow.
I've gone
will
on the
move.
slideshow.
But
gone
no. Still, we are seeing the slide sorter only.
Oh. I've actually gone on. I'll do this again. Stop share. Now I'm going on the slideshow. I've gone on the slideshow. Is that okay?
You
No,
go to the
ma'am.
next.
No,
you go
you
to the
have
next
just
slide, ma'am.
uploaded the
Go to
slide.
Next slide.
You have not gone on the slideshow yet.
In my laptop, I can actually see the.
Slides moving.
Yeah, I can see the slides moving. Okay, let me try this
You
again.
start first slide, ma'am.
Is that okay now?
Yes, now it's
This is
okay.
fine. This is fine.
Okay.
Yes.
Now, yes, ma'am.
Okay.
Now it's correct.
Okay, fine. Thanks. So
Thank you,
can I move to the second slide?
Yes.
Right. Okay. So I just mentioned that today we are also looking at preeclampsia on the basis of hypertension and signs of maternal organ dysfunction other than proteinuria. So therefore you can have preeclampsia without proteinuria. That's a point which I wanted to make. Now, when you're looking at a classical definition, HDP is defined as systolic blood pressure of 140 millimeters of mercury or more, or a diastolic blood pressure of 90 millimeters or more, with the patient seated, rested, and not cross-legged. And this is by a calibrated sphygmomanometer with the right arm cuff at the heart level. And what does HDP include? Gestational hypertension, preeclampsia, eclampsia, as well as chronic hypertension. Just quickly go over certain historical facts. We'll quickly go through these slides. Earlier times, multiple therapies were used, like the lytic cocktail, like the high doses of diazepam, like the Maxelf enemas, like only Eptoin. Way back in 1987, when I joined the Sion Hospital, and that time it was KM and Sion which had started using Maxelf. So in 1997, 10 years later, I presented the data of eclampsia management before Maxelf and after Maxelf. And we had analyzed nearly 16,000 deliveries over 2 years. The incidence was 1.8%. And what we found was the maternal mortality had definitely improved with Maxelf as compared to the usage of lytic cocktail. But by international standards, it was still very high. And what we also found that previously, women were dying on their way or at their homes. So now at least the trends of shifting to the hospital had started. Yes, there was a delay in transfer because it probably had more than 8 to 10 convulsions before they reached the hospital. So already had complications and went into multi-organ failures. Now, post-collaborative eclampsia trial, there was a change of mindset of doctors, but the change to Maxself took nearly 10 years. Because in 2005, when the Avni Foundation did a survey of Maxself utilization, they found that probably there was a supply shortage, or there were lack of institutional guidelines, or probably just a lack of knowledge by the healthcare workers. And gradually the availability and the use of Maxself increased. The fear of using that new drug reduced, and training for emergency obstetric and neonatal care also improved. In 2011, Dr. Sanjay Gupta started the National Eclampsia Registry. This helped in quantifying the magnanimity and also the clinical relevant pointers. And what was realized, there are so many complex pathogenic mechanisms for this disease called gestosis. So the chapter of organization gestosis was initiated, and Hema Divakar was the first president of the chapter. Now it is known as the Gestosis India Association. Now, many preventive strategies have been suggested, but only few have been proven to be scientifically correct. But we all know that early antenatal care, clinical risk assessment, biomarker possible, post vigilance, and calcium and nutritional supplements are probably useful. And in 2014, when I took over as president, we felt that it was necessary to standardize the management. And so our team formulated guidelines and initiated the certificate course. Mind you, it took us nearly 6 months to finalize everything with the help of 40 experts. And this was known as the Foxy Gestosis HDP course with 12 modules. And we managed to do around 800 courses and sensitize 15,000 people. And even now we do carry it on time and again. And in the same year, we had the gestosis guidelines. And in 2019, 3 years later, we revised those guidelines. Now, what are the important changes? One thing definitely, that the awareness has increased. Our gestosis team has got the gestosis score for prediction of preeclampsia. I'm going to talk to you about it later. People have realized that we have to do an aggressive management of preeclampsia, and most of the places have changed over to Maxself because this is now the gold standard for prevention and treatment. Eclampsia drills are now a regular feature at medical colleges and many conferences. There are newer drugs coming for lowering of blood pressure. People have understood that steroids are essential for lung maturity, particularly in preterm preeclampsia. And now there is a concept of high dependency unit and availability of ICU as we are understanding the complications. And I would definitely say that Government of India, Foxy, Gestosis India Association, and many associations all over the country have worked in tandem to highlight seriousness of the problem and need for early screening of HDP. So the Indian eclampsia incidence is 8 to 10%, preeclampsia is 8 to 10%, and eclampsia is in about 1.5% of the cases. But we remember that 2 to 23% of the maternal deaths are because of this. So if you're looking at the maternal mortality ratio, has there been any change over the years? We all know that it has dropped down from 167 to the data which we see in 2014-16 to 130, 122 in 2015 and 17, and this is registered as 6.15% reduction. Now, what is this reduction? Probably there is a better control of PPH and HDP, and therefore we can definitely say that treating HDP with magnesium sulfate has positively impacted MMR. And of course, the government has got the Janani Suraksha Yojana promoting institutional delivery, but we still know that there are gaps, suboptimal quality of services, and these are the things which we have to look into. So then coming to these guidelines, how have they been useful? Obviously, it gives us an updated, scientifically correct definition, identifies effective screening and predicting modalities, emphasizes strategy for preventing and the necessary diagnostic laboratory investigations, as well as standardizing antihypertensive protocols. And friends, today we must prevent eclampsia and other complications by initiating early and effective management. So let's quickly go on to the classifications. We know that there are many, But we must remember that the recent classifications are better for clinical usage and they have a superior reflection of associated pathophysiology. Nice classification, everybody knows, mild, moderate, severe. But today, according to the current classification, hypertension should be classified into severe and non-severe. So when we say non-severe, it is mild to moderate. So anything that is between 140 to 159 systolic and 90 to 109 diastolic will be mild to moderate, and severe will be 160, 110 or more on 2 occasions 4 hours apart. Of course, that doesn't mean you don't start treatment. You institute treatment immediately, but to label it, we have to take readings frequently. Proteinuria, oliguria, cerebral or visual disturbances, pulmonary edema or cyanosis, the epigastric classic upright upper quadrant pain, impaired liver function, thrombocytopenia. But mind you, what is the change? The grade of proteinuria and the fetal growth restrictions are not significant in determining severity because there could be other reasons for both of these problems. So if you're then looking at the clinical classification, which probably helps the clinician a little better, we remember that late onset preeclampsia is a maternal disorder due to underlying maternal constitutional factors, and usually the placental volume is normal. The fetal growth may be almost normal because the Dopplers are normal. There may be a fairly normal birth weight, and usually there are favorable maternal and perinatal outcomes. But in the early onset preeclampsia, which we are worried about, it's a fetal disorder typically associated with placental dysfunction. So there's a reduction in the placental volume, fetal growth restriction. There are abnormal Dopplers, and that's where we rely on our fetal medicine team to pick that up. There is a lower birth weight and therefore require much more vigilant monitoring, optimal times to deliver, and there may be adverse maternal outcomes if we are not vigilant enough. So friends, then the aim of any obstetrician today is screening and surveillance of preeclampsia. The early the diagnosis, the better it is. Aggressive treatment, along with that fetal surveillance, timely delivery, and prevention of eclampsia. So now I want to tell you a little bit about the predicting modalities, particularly applicable to the low resource settings. The Gestosis score, which is based on high risk factors. This concept was initiated by Dr. Gorak Mandrutkar and then developed further by our Gestosis team. And this is now being done in various places and we are awaiting validation. This is available on your Android app. You can download it from the Play Store and use this. And let me tell you what this score is. On the left-hand side, all the factors have got a 1 score. So women who were themselves small for gestational age younger than 20 or older than 40, BMI between 26 and 30, nulligravids, family history of preeclampsia or cardiovascular disease, PCO, interpregnancy interval of more than 5 years, and maternal hypothyroidism. So all these get a score of 1. Whereas gestational diabetes, obesity more than 30, that is BMI more than 30, multiple pregnancies get a score of 2. But the moment you have a patient who's had an HTP in the previous pregnancy or a pre-gestational diabetes, chronic hypertension, inherited or acquired thrombophilia, they all get a score of 3. Maternal chronic kidney disease and assisted reproduction. Of course, this does not include IUI. It is only IVF, ICSI, or the higher order. They all get a score of 3. So if by totaling the first antenatal visit, when you've taken everything, you've looked at all the factors, you give a point of 1 to 3. And if the sum total is 3 or more, then the woman should be marked at risk for preeclampsia. And if it is 3 or above, please start the preventive measures in the form of low dose aspirin between 75 to 150 and calcium, particularly in the low calcium intake group, 1 to 1.5 grams as early as possible, and continue it throughout the pregnancy. And of course, when you're looking at prediction models, there are others. There is the Pyers prediction model, mini Pyers and full Pyers, but these were basically, again, they are applicable to the low resource setting, particularly to know when to transfer the patients. So if you're looking at a mini Pyer score, they again look at factors like parity, gestational age, chest pain, whether there are symptoms, presence of proteinuria, and these patients probably would benefit with interventions like MaxSelf and shifting to a tertiary care. And full Pyers, of course, with all the mini Pyers points, there is also platelet counts and the biochemicals like the creatinine, aspartate, transaminase, and these probably would help the doctor's ability to recognize women at risk for complications. So probably be more vigilant and intervene in the management. Now, when you're looking at uterine artery Dopplers, now these are again predictors, and they have been shown that if there is an increased resistance to blood flow in the uterine arteries, it is going to be associated with a gestosis problem and preeclampsia. And histopath has correlated with the preeclampsia in this. So obviously, I don't need to tell this August audience that color flow mapping, pulse wave Doppler, we don't look at diastolic notches, but calculation of pulsatility index is important, and anything more than the 95th centile is deemed as high risk. So if you're looking at the first trimester scan, we are doing the nuchal scan with the dual marker. If you're having a PAPA mom of less than 0.5, this is predictive of a placental function leading to an FGR. And umbilical artery, obviously, if you're going to combine maternal factors and uterine artery PI rates, it may improve detection rates of preeclampsia right from 36 to 59% with a false positive rate of 5. But if the screening is positive, then low dose aspirin and regular fetal monitoring can be done. Now, what has happened is there are also certain biochemical parameters. PAPA, I don't want to go into too much detail over here, but we must understand that this glycosylated protein, if it is low, it is associated with a higher incidence of preeclampsia and FGR. And if you're looking at first trimester PAPA and second trimester S-split and placental growth factor, I'll just talk about this a little later also, this could predict late onset preeclampsia with a detection rate of 87.5% with a false positive rate of 5%. And there is another new thing which has come up is a placental growth factor. We all must understand that if the placental growth factor is falling down, these are the mothers who are probably at risk for preeclampsia of a small for growth gestation babies. And detection rate of 55% and 33%, good detection rate, but then they still have a false positivity rate too. So these are very confusing combinations. But if you're looking down the line, you know that maternal factor plus a mean artery blood pressure plus a uterine artery PI plus a PAPA plus a placental growth factor probably gives a better detection rate. So more combinations give better detection rates. But then practically, is it possible to do this everywhere? So the Fetal Medicine Foundation came up with certain other characters. They call it the ASPRAY trial. They did the maternal factors like the age, height, weight, parity. They looked at the IVF conceptions, the blood pressure, the diabetes. They put on their risk scores over there. And along with the blood pressure, they also did the nuchal scan, dual markers, and they studied the Doppler's flow. And herein what they found was if the women are having a positive screening test with the combination of all these, then these are mothers who are at a very high risk for developing preterm preeclampsia. And so they recommend giving low dose aspirin 150 milligrams from 11 to 14 weeks of gestation right up to 36 weeks. And this reduces the incidence of preterm preeclampsia by more than 60%. So they claim that this screening is much more superior to the NICE guidelines, where NICE was looking only at the high risk group of 10 factors, and ACOG, that is American College, were recommending use of aspirin only in women who've had a history of preeclampsia and more than one pregnancy. So probably they were missing out on a lot of women, and the ASPRAY trial probably shows a lot more promise. Now let's look at the angiogenic biomarkers, the S-FLIT, which is basically an anti-angiogenic protein. which antagonizes growth factors like VEGF, levels of S-split increase prior to the onset of the clinical disease, and then they appear to correlate with the disease severity. So if you have a ratio of raised S-split to the decreased placental growth factor, then this particular ratio gets elevated prior to clinical onset of preeclampsia, and this can alert the clinician for preeclampsia. So this was a part of the prognosis trial, and they found that the ratio of S-split to placental growth factor is a valuable aid in diagnosis of preeclampsia and discriminates between different types of pregnancy-related hypertensive disorders. So if you have a value of 38 or lower, then this can predict absence of adverse maternal and fetal outcomes within a week. And just a few lines about the PARROT trial, which was being carried out in the UK. In the PARROT trial, a single placental growth factor test was done in women who came to the maternity unit with suspected preeclampsia. So in women who had the test result, it halved the time to diagnose, meaning they could be diagnosed much more earlier. And this significantly lowered the chance of serious complications in women. Of course, there were significant false positives and negative diagnosis, and sometimes this resulted in increased morbidity or unnecessary intervention. So then what is the conclusion and what should we be following? Though we understand that we have a lot of people very well trained in Dopplers and biochemical markers are not available everywhere, but it is still available in many parts of India. It's a good way of prediction, but only resource-rich centers can offer this. Public hospitals have got huge numbers of patients and they don't always have the trained manpower and machines. So therefore, what do we do? And that's where we come to the gestosis screening, the gestosis score, which is very easy to do at the first. At least those women are given the options and they are given the low-dose aspirin. It could be at the first visit or the second visit, but they are at least given that, and that prevents to a certain extent the preeclampsia. Government of India currently recommends 2 scans in pregnancy, but they talk about the mandatory one as being the anomaly scan. So let's hope that gradually more and more people are trained to look at, and we have more resources to look at the biochemical markers. And of course, there is a new test which is coming in from the third world, and maybe it might be useful, the Congo red urine test, which identifies misfolded proteins with color changes in pregnant women with preeclampsia, but still it is undergoing trials to be able to say that it's a reliable test. So now let's move on to the measurement of BP. I think everybody knows about this, but 2 things that I'd like to mention specifically over here. The cuff size has to be appropriate, particularly in very thin women and in very obese women, and put the cuff at the right place at the level of the heart. And you're looking at Korotkov 1 for SBP and 5 for DBP. But if you find that the diastolic is persistently less than 40, use the muffling of the 4th sign and make a note of this. And yes, we love our mercury sphygmomanometers, is the gold standard. But today at many places, you have these calibrated aneroid devices or the automated BP machines. Make sure that time and again, they are calibrated to the mercury one. And remember, while taking the BP, particularly in very busy places, the patient should be comfortable, the bladder should be empty, she shouldn't have chewed tobacco or taken strong coffee prior, and she should be relaxed. Let her sit down, quiet environment, and then take the blood pressure. Because if you find that the BP is high, you may have to repeat it twice and thrice. But if you find that the first 2 readings are 140 or above and diastolic is 90 or above, then you can omit the 3rd reading. But do check out the proteinuria. If you find that there is a BP more than 135 or 85, be alert. So frequent BP checkups at home or from a healthcare provider or an ASHA worker at least twice a week, this can be definitely considered. And counsel the mother about the risks and the need to come for a follow-up more frequently. And at every visit, ask about specific symptoms: headache, visual disturbances, right upper quadrant pain, swelling all over the body. And remember, whenever there is preeclampsia, it should be assessed in the hospital when it's first diagnosed, because later, once you're sure, then you can manage it as an outpatient. So if you have a daycare, you can look at the patient, monitor, do some tests, or maybe have a one-day admission. Once she's stable and you feel that she's counseled enough to rely, she will be calling you back for the, she'll be reporting back to you if there is any problem or blood pressure, then only you can discharge her. So what are the lab investigations? Basic ones: urine for protein, CBC, liver and renal function tests. Now, though we talk about 24-hour urine protein, it is not practically possible to do it. So most of the labs have now started doing a protein creatinine ratio and a LDH level. Do we need to do a coagulation profile every time? No. Only if the platelets are low, you can get the report from the CBC, then do a coagulation profile, do the ultrasounds and Dopplers. And if you feel that there is an abnormal BP, and if you feel that symptomatically the patient is not looking good, admit her, look out, watch out. And if you feel she's looking fine, you can discharge her, but call her back maybe 2 days later, 3 days later, if you find there is 1+ proteinuria, and maybe reduce the interval for repeat evaluation depending on symptoms, biochemical parameters, and fetal condition. If the diastolic blood pressure is more than 90 or less than 100 and there's no proteinuria and no symptoms, repeat after 48 hours. If it's 2+ or more on dipstick, she's got no blood pressure or no symptoms, repeat again the blood pressure after 48 hours. But repeat the preeclampsia evaluation within a week if you feel that there is just 1+ of proteinuria, but there is no other symptom. And you may reduce the interval of repeat evaluation depending on symptoms, BP, biochemical parameters, and fetal condition. So coming to the management, remember, treating hypertension is better for the mother without increasing risks for the baby, as severe hypertension can lead to adverse maternal and perinatal outcomes. And prevention is always better than cure. So prevention of development or adverse effects is much better. And the golden question: when do you initiate antihypertensive therapy? Laura Meggie in the CHIPS trial has beautifully brought this out. And she says that antihypertensive therapy is recommended for an average systolic blood pressure 140 or more, diastolic 90 or more in a pregnant woman with chronic hypertension, gestational hypertension, or preeclampsia. And we are not now looking at a diastolic of 100 or a systolic of 150. It is 140, 90 or more. If a woman is already on antihypertensive therapy, then you can look at a diastolic of 85 or more. And if the patient is already on antihypertensive therapy, and if a diastolic is dropping to 70 or 80, you have the options of reducing the dose of antihypertensive therapy, or you could stop it. But if it is more than 85, you can increase the dose. But remember, you have to titrate the dose, and a tight control is much better, as is brought out by the CHIPS trial. Why are we so worried about the blood pressure? Obviously, I think we all know about the CV accidents, eclampsia, much dreaded complications, cardiac failure, abruptions, but even isolated systolic hypertension is an independent risk factor for stroke. So friends, we have to be very, very careful. Do not ignore this, because the complications of eclampsia, the HELP syndrome, the CNS problems, breast which is on the rise, visual disturbances, renal issues, pulmonary edema, all these are fairly common. Liver involvement is relatively rare, but the subcapsular hematomas can occur if the patient starts getting right upper quadrant pain. Always suspect that. Compromised uteroplacental circulation, particularly in the early onset preeclampsia, coagulation failure, DIC is multi-organ failure and death, and you definitely want to prevent these complications. So then how do you manage a mild? Now, when I see a mild, I mean a mild to moderate, non-severe preeclampsia, as per the new definition, can be managed expectantly until fetal maturity, that is 37 weeks, and completion of 37 weeks, and also till spontaneous onset of labor if the BP is well controlled. If you need any time, you can do a day's hospitalization for the BP monitoring, the fetal evaluation. If the PCR is not available, then assessing 24 hours proteinuria and evaluating any other system. But when it comes to management of severe preeclampsia, then one has to be more vigilant, because once more, I want to tell you that the extent of proteinuria does not predict the morbidity, neither does the severity of the FGR, because these can occur in the absence of PE. But the moment you see that 160, 110, you know that you have to be very alert and start investigating and treating the patient, because you don't want her to progress into eclampsia or stroke. And management of severe preeclampsia is based on the principle that delivery is always appropriate therapy for mother, but may not be so for the fetus. So if there is a rationale for management other than delivery, it would probably be to palliate the maternal condition so that it gives a little time for the fetal maturation and cervical wrapping. So the principles: prompt hospitalization, as safety of the mother and fetus are very, very important. Magnesium sulfate to prevent convulsions. I've written IV, but you can give IM. But IV, the first is the loading dose, which we always prefer to give IV. And then you can move on to the Pritchard's regime or the Zuspan's regime, as is convenient at your setup. Antihypertensives, steroids, once the BP has stabilized, and delivery when appropriate. So I've already mentioned about when to start the antihypertensives. But the choice of the agent, we must remember, will depend on the obstetrician's experience, the patient, and availability. And we must not have a sudden precipitous fall in the blood pressure. So when you're looking at the care plan summary, anything less than 25 weeks, stabilize the patient and terminate the pregnancy. Between 25 to 33 weeks, you have that little time for expectant management, for steroids, for Maxel for neuroprotection, and then deliver if maternal or fetal condition. And more than 34 weeks, stabilize the patient and deliver. Now, this 25 weeks gestation, like in a place like Surya or where there are good NICUs, we are able to salvage these babies. But in a setup where NICU care, tertiary NICU care is not available, this gestation could be 26 weeks also, or even 27 weeks. But then the life of the mother is important, and we have to consider termination, or hopefully give her Maxelf and transfer her, if there is time, to a center where there is availability of maternal and neonatal tertiary care. So what are the antihypertensives? I've already mentioned. Correct dosages, rational combinations are important. Stabilize the BP, and the first line therapy today is labetalol, nifedipine. Alpha-methyl dopa is not easily available everywhere now, and it was never used for acute hypertension or for severe. It was used for the non-severe variety, but it is no longer available. But in UK and in some of the countries, it is still available. So that's why I've put that drug here. And nicardipine, this joins the armamentarium of first-line therapy. And drugs which we never must use: ACE inhibitors, beta blockers, and diuretics. Atenolol, we are still awaiting trials to know whether it's really should be used or not, but ACE inhibitors definitely no. Labetalol is the hot favorite now. It's a category C drug, alpha and beta adrenergic blocking agent. The advantage is it can be given orally as well as IV. Gradual fall in blood pressure, it improves the lung maturity as it's going on, and it can be given in the non-severe and the severe varieties. But remember, in a day, don't exceed 2,400 milligrams, and it does cause transient tachycardia. But if you feel that there is bradycardia, CCF, or a brittle diabetes, don't use labetalol at all. In that case, nifedipine is a much more easily available drug. It's popular because it's available, it's not expensive, it reduces the mean arterial blood pressure, it can work in both non-severe and severe. It works very well in cases of bradycardia, 10 milligrams every 4 to 8 hourly, non-severe. But in the severe variety, 10 milligrams to be repeated after 30 minutes. And once the BP is controlled, you can shift to a sustained preparation. It does cause nausea, headache, and fall of BP, but please monitor the patients. But don't ever give it sublingually, because it can cause a precipitous fall in the BP. Nicardipine, this used to be only with the cardiologist, but the big advantage is it's the same family as nifedipine. It is more selective for cerebral and coronary blood vessels, 100 times more water soluble than nifedipine, and so can be given IV easily titrable, and onset of action is 5 to 15 minutes. Oral tablet produces drop in both the systolic and diastolic BP. And if you're giving an infusion rate, you can start off with 5 milligrams per hour, and you can increase the dose to a maximum of 30 milligrams per hour till the desired BP is achieved. Then what about alpha-methyl dopa? Yes, it's a category B drug. Usually, it used to, earlier times we used to use it even for severe preeclampsia, but now it is only for the non-severe chronic hypertension. It used to be reliable, easily available, but then it had its adverse effects and currently not available. So I haven't used it for the last 3 years. Antiplatelet drugs, well, these don't really reduce the blood pressure, but then if you're giving it from 13 to 36 weeks as per the ASPRAE trial, or as per our gestosis score, give it at the first visit itself in patients who got a high gestosis score, then it helps in the delay of the onset of the preeclampsia. And low molecular weight heparin, no, it does not prevent preeclampsia at all. But women who are thrombophilia screen positive, documented with a history of DVT, previous history of abruption, recurrent pregnancy loss has only got a role over there. So looking at this summary of drugs, labetalol I've already mentioned, but don't use it in cases of CCF, diabetes, or asthma. So check the pulse before giving it. Nifedipine and nicardipine are there to help us out and lower the BP promptly but slowly. And remember, all these are category C drugs. Human studies are lacking, but then these are currently drugs which we are having. Labetalol can be used by the Parkland regime, CPAP regime, or the KCOG regime, whichever is the one which is more suitable. But what we generally prefer is 10 to 20 milligrams IV, and then you keep giving 20 milligrams every 20 to 30 minutes till you've achieved a maximum of 300 milligrams. What about hydralazine? Yes, this is a dangerous drug, but it's a very helpful drug because it causes direct relaxation of vascular smooth muscle, drops the BP. But friends, the BP drop can be so severe that the patient starts getting increased heart rate and can have an increased cardiac output, which can precipitate a CCF. So therefore, if you're using it, use it at a time when you're sure you are moving the patient to the theater, you want to control that blood pressure, you're waiting for the anesthetist to come to deliver only in that much time, and with strict monitoring, monitor it very, very slowly, very, very strictly, and make sure that you don't run an infusion. It has to be handled with care. So hypertensive crisis, we all know what it is. There's an end organ complication, but that is in an hypertensive emergency. In an urgency, it is almost the same thing. The only difference is it is without end organ complications. So you have a little time to start with the drugs. But prevention of seizures is very, very important. Magnesium sulfate is a wonderful drug as shown in prevention of preeclampsia by the MAGPIE trial. The same dose is to be used. But what we must remember is it is not recommended solely as an antihypertensive. You have to use your standard antihypertensive therapy, and you have to monitor the baby also, because you have to decide what to do, how to deliver. And if you feel that the blood pressure is not responding and you have to use an NTG infusion, please involve the cardiac team, because this should be given in an ICU setup with strict ECG monitoring. And even when you're talking about use of sodium nitroprusside, use it only when you're sure that you're going to deliver immediately. So let's go back to this MAGPIE trial. It's a wonderful trial, huge number of patients, and clearly has been shown that it prevents eclampsia and reduces the maternal morbidity, mortality, and also the newer evidences which are suggesting that there is a neuroprotection to the fetus, particularly between 26 to 32 weeks. Early preterm birth, if you're expecting, give Maxil. It helps the mother, it helps the baby, reduces the risks of cerebral palsy, and protects the gross motor function. And effects are greatest at early gestations, particularly when you're expecting the delivery within 24 hours, and the loading dose is the same. So back to Maxil. we all understand that Maxilf is the gold standard because we find that the risks of maternal mortality and perinatal outcomes are much more better by the cerebral vasodilatation. It blocks the NMDA receptors, reduces the calcium influx, and therefore alters the neuromuscular transmission and protects neuronal damage. And it causes a peripheral vasodilatation and is a calcium channel blocker, but you can use it concurrently with nifedipine. Please don't stop. You can use nifedipine along with this, and everybody is aware of these particular, how to prepare it. But put these charts up in your labor rooms, and instead of the 25% weight by volume, choose to use the 50% weight by volume. Very easy to give it. So the IV dose is 4 ampules of 50%, which is 8 ml, 4 grams diluted with 12 ml, slowly over 15 to 20 minutes. And IM, 50% solution, 10 ml, 5 grams in each buttock. And one practical tip is clean the buttocks before giving the Maxilf, because if it is unclean and you haven't used betadine, it may lead to abscesses, and they're very, very painful. And 1% of 1 ml of xylocaine to reduce pain at the injection site. So today at many of the bigger hospitals, we've switched over completely to the IV regime, the Zuspans regime. Results are the same. The loading dose is the same. The only advantage is the patient doesn't get the pain and you're not worried about the abscesses. So it's easy to use it. But yes, in medical colleges, sometimes when there are many patients, they're still preferring the IM dose. Results are absolutely the same. But remember, whichever one you use, continue it for 24 hours post-delivery or post-conversion, whichever is later. And the collaborative trial has clearly shown there is no difference in the outcomes at all, excepting for the pain, which is associated with the intramuscular injection. And monitoring patellar deep tendon reflex. Mind you, if you cannot do this because the patient is very obese, you have your triceps, biceps, supinator jerks, you can do the ankle clonus, because these reflexes are the first to go if there is toxicity. And respiratory rate should be 16 or more, and urine output should be 30 ml or at least 100 ml in the preceding 4 hours. And if you find that you've given the Maxilf and the convulsions are recurring, you are allowed to give 2 grams of 50% Maxilf IV over 5 minutes. This is very important, that giving slowly, because you don't want the patient to go into an arrest. They can be a neuromuscular blockade and there can be a sudden death. So look at the clock. Books and the trials have recommended 3 to 5 minutes. I always used to tell my residents 7 to 10 minutes. So that 7 to 10 minutes, you'll realize how long is it, but you'll at least give it and there will be no problems. Because you want to maintain a plasma level of 4 to 7 milliequivalents. The more you go higher, the patellar reflex disappears. 8 to 10, there is uterine relaxation. 10 to 12, you start getting respiratory depression, which means the respiratory rate goes down, and more than 12, there is a respiratory paralysis. So do you really need serum magnesium levels? It's expensive. It's not superior to clinical monitoring. So if it's available in the ICU, do it, but otherwise there's no real need to do it. And this is the way we prefer charting the pulse, BP, the urine output, the reflexes, the Maxilf dose, particularly the time that has been given, exchange of duties, this can be a big problem. And there are side effects. But those side effects, nausea, vomiting, thirst, these are very, very, very nominal and they go away. But if your doses are becoming more, yes, then that can be a risk. So therefore, monitoring doses are very important. If your patient has had Maxilf and the anesthetist wants to give GA because regional is not possible for whatever reason, please tell them, because there could be interaction. They will reduce the dose of their muscle relaxant and inform them whatever is there. If there is an absent patellar reflex, withhold the Maxilf, wait for the reflexes to return and restart at a reduced dosage. What if the urine output is less than 100 ml? Well, first check the catheter. Sometimes the catheter is out. So if the catheter is in, check the patency. And if there are no other signs of toxicity, reduce the dose to 2.5 grams. Make sure your labor ward or your eclampsia room has got all the equipments available. The oxygen, calcium gluconate. Keep that. That's an absolutely precious drug. 10 ml of calcium gluconate, 10% over 10 minutes. This is the rule of the 10 if there is a respiratory depression. And intubation facilities, immediately intubate and ventilate. Stop the max self, give IV gluconate and continue ventilation to the normal spontaneous respiration occurs. So therefore, your residents in labor ward must be trained for this, and that is the intubation, and or you must have access to an anesthetist who immediately comes. Like in Sion, we had the anesthetist practically in the labor room because the number of deliveries were 35 to 40 a day. So there used to always be an anesthetist around. But remember, when this is not a situation, you have to train whoever is going to look after the patient. So management of severe preeclampsia is based on gestational age, which we've already mentioned. Expectant management only should be done when you know that this is a tertiary care and we want to decrease the effects of prematurity. But at the same time, the delivery should be planned. The mother reaches 34 weeks. Don't just try to pull on the gestation in case of severe preeclampsia. Deliver the mother by then. So back to this care plan, 25 to 33 weeks, you can give us steroids once the BP is settled down. Give that max self for the mother, for the neuroprotection, and deliver the patients once stabilized. But more than 34 weeks, if you wish to give steroids, you can stabilize the patient and deliver. I've already mentioned about this. But just a word about corticosteroids. We used to like betamethasone, but it is no longer available in most of the parts of Maharashtra. So now we are using dexamethasone. It could be a dose of 8 milligrams every 8 hourly, or 6 milligrams 6 hourly, or 12 milligrams 12 hourly also. And if you feel that the initial evaluation of multiple organ is there, you could give it at 12 hours and decide to deliver. But the principles of expectant management must deliver. The parent should be counseled, the patient should be counseled, and the relative should be counseled. And we must do it in a tertiary care because you have all the specialties, anesthesia, neonatology, the obstetric team and operating room staff. Everybody should be available around the clock, and clear surveillance guidelines should be there. Don't just do it in a smaller place because you might get caught out there. So consider expectant management in pregnancies less than 34 weeks of gestation. If there is no organ involvement, that is other organs, thrombocytopenia, no evidence of HELLP syndrome, no symptoms of cerebral irritation, no labor or no abruption, and of course your NST should be good. But if any of these are a problem, please consider delivery. And a relative contraindication is if you feel that the fetus is severely growth restricted, has got oligoamnios or organ involvement, please consider delivery. And when you're monitoring the mother, what would you do? You would look at the BP every 4 hours, urine albumin every day, strict intake output chart, and repeat the lab test every 3rd or 4th day. And what are these lab tests? Platelet count, LDH, because rise of LDH is a marker for early help, SGPT, SGOT, and serum creatinine. And fetal monitoring, obviously with the fetal kick count, but NST is important. And your ultrasound with Doppler, AFI, check all those out, estimate the weight of the fetus, and finally take a decision. So what are the indications for delivery? If something goes wrong with the mother, or if you feel something going wrong with the fetus, please consider delivery and ensure availability of HDO, ICU, and NICU. So if there is an uncontrolled severe hypertension, cerebral irritation, persistent thrombocytopenia, shortness of breath, HELLP syndrome, renal impairment, don't wait for the full-blown HELLP syndrome because you'd rather deliver her at the earliest onset. If there's a renal impairment or clinical signs of abruption, don't waste time. Please deliver. Don't worry about your C-section rates right now. And fetal indications, we've already mentioned. If there is a severe growth restriction or decelerations and absolutely flat NST, oligoamnios, please consider delivery. And if the fetus is dead, do not continue the conservative management. So decision making about the mode of the delivery. Decide about the need and urgency to deliver. Assess the patient's general condition. Remember, check the gestation, presentation, and position. Obviously, you're going to do a vaginal examination to assess the Bishop score and all the other things that go into decision. Now, in case of a preterm gestation, The Bishop score is usually poor, less than 3. The presentation could be a floating head, breech, oblique, or a transverse lie, and you feel that the need of delivery is urgent, please do a C-section. But skillful delivery backed by experience will help us in dealing with challenges of delivering baby as a lower uterine segment is poorly formed. Now, if the Bishop score is more than 3, then if the presenting part is fixed and you feel that the patient is stable, you can consider induction of labor with the strict monitoring, but recourse to the section wherever indicated. Now, in case of an eclamptic patient, ensure that she has already received magnesium sulfate, antihypertensives, and optimal fluid management. If she is in labor, then consider rupture of membrane, assess color of the liquor, and allow her to deliver. But after stabilizing the patient, if you feel that the score of the cervix, the Bishop score is less, don't hesitate in going in for a C-section. So just looking at this particular summary, non-severe, that is between 38 to 40 weeks, you can actually individualize and deliver. Abnormal fetal test, fetal growth restriction, in those situations, you can consider delivery much more earlier. But as I've already mentioned, in cases where you feel that there is a need to wait, please just wait. This is just an algorithm which we had developed during our gestosis course. So anytime you feel there are any complications which require a multidisciplinary management, please consider delivery in a tertiary care. And this is again a chart which we had developed. I'm sure most of you will be having the eclampsia charts, but this is important to know. And if it is multicolored, it quickly catches the attention. Remember, everything should be ready, and that's why the eclampsia drills are very, very important. And the thing which people, they know about the doses, they know about the, what exactly investigation to send, but they forget about the fluid balance chart. So make sure that you don't want a fluid overload, and maintenance dose, the doses of the max shell should be nicely charted out, and auscultate lung bases early for finding out pulmonary edema. So what are then the advantages of an HDU? A dedicated obstetric HDU with the knowledge, experience, and expertise of an obstetrician and a specialist team, they would be ideal for monitoring. And thanks to Dr. Alpesh Gandhi, because he popularized this concept with the government. The advantage is it continues antenatal, intrapartum, and postnatal care by the same team, and care in an HDU avoids exposure of the critically ill pregnant woman to other ICU patients, and patient satisfaction rates are much better as it is less noisy. So if there is any complication which we are seeing in the charts, these are the usual indications for admitting patients with severe preeclampsia or eclampsia to the ICU. And of course, then you have your multidisciplinary team, you have to manage and monitor them well. I'm not going to go into details of complications because then we'll exceed our time talk, but I'd like to mention that any multidisciplinary team, if you're planning to shift, there has to be a coordination staff where these people will be alerted that such a patient is coming and she needs to be treated. Therefore, the concept of communication between teams is very, very important. What about atypical eclampsia? Watch out, because here is where we can get caught out. Any woman who's got hypertension, proteinuria, headaches, blurred vision, even before 20 weeks or 48 hours post-delivery should be considered as an atypical preeclamptic. We're seeing more and more of these cases. So there could be a capillary leak syndrome comprising of ascites, pulmonary edema, proteinuria, and these are all associated with the multi-organ dysfunction. So if you feel the presentation is atypical, please consider preeclampsia or eclampsia, do the biochemical and hematological investigations, and start the treatment. Of course, in these situations, rule out multifetal, molar pregnancies, multiple problems like viral hepatitis, ITP, and antiphospholipid antibodies. And if there is an atypical preeclampsia, antihypertensive drugs, magnesium sulfate, fluid management, and a timely delivery, vigilant monitoring in an HDU is very, very important. Now, the last few slides, postpartum period, we must remember, once the patient is delivered, we are also relieved. But in the early postpartum period, women with preeclampsia can worsen. In fact, they can start convulsing. So for the 3 to 4 days, keep them in the hospital. Don't be in a rush to discharge them. Monitor them, because the hypertension may worsen transiently, and sometimes it may even manifest for the first time. So be very careful. So continue your antihypertensive therapy and gradually start reducing the dose over 2 weeks and monitor the BP. So if you're discharging the patient, say on the day 6, call her back in 2 days' time, because you need to monitor the BP. And in the early postpartum period, you will be surprised to see that there can be sudden bout of convulsions which have never occurred in the pregnancy. So watch out and avoid NSAIDs, particularly in women who have had a kidney issue or with placental abruption. Use some other analgesics. Today, you have so many others apart from the NSAIDs. And hypertension, proteinuria, and biochemical changes take about 6 to 8 weeks, but sometimes they may persist for longer. So please manage the BP, screen for secondary causes of hypertension, and women who've got resistant hypertension, impaired renal function, abnormal urine analysis, please consider an appropriate referral to the physician or the nephrologist. And also remember, the patient has gone in through a lot of stress. There could be a lot of anxiety, depression, mental health implications. So watch out for these. And if you feel she requires counseling or requires psychiatric counseling, please do so. And in the long run, women who've had hypertension in the pregnancy and now are normotensive, they need assessment for traditional cardiovascular markers, because this is so important, and they should be counseled for a healthy lifestyle, particularly if they're obese, reduce weight, and care beyond 6 weeks. I just wanted to specify this once more. Do not forget to call them back and get them treated for the underlying cause of the hypertension. And friends, we are a country where we don't always discuss about contraception, where we know that population stabilization is most important agenda. So discuss about the contraception. We sometimes feel patient is so serious. What can we talk? Talk to the relatives about it. And once the patient is stabilizing, talk to her about contraception, because IUDs, progesterone only pills, implants are all available. If she wants to conceive in future, let her do a preconception counseling, but please emphasize the contraception very, very strongly. And thank you very much. I could just go on and on and on, because this is a subject very, very to my heart. And once again, I thank all of you. Yellargu namaskara and Yellargu thank you for patiently listening. And thanks very much to Dr. Muralidhar Pai for giving me this opportunity to speak about this particular issue. I'll just stop here.
Yeah, thank you, Dr. Suchitra, because it was so comprehensive. It was almost like a monologue or a just book on preeclampsia. And you have touched upon all the aspects, the recent advances, the emergencies, and everything. So it was so comprehensive. I'm sure it was not only helpful to our practitioners, also I'm sure some of the postgraduates must have been logged into this. It is a very, very good lecture for them. I can see Dr. Bharati Rajshekhar. So Manjula, can you request her to ask questions, conduct the Q&A session?
Bharti ma'am?
Good evening, Dr. Suchitra Pandit. Thank you for this very, very exhaustive topic covered in a very short time. And you have given us all the information, and practitioners and consultants have had a revisit to the recent guidelines of management of preeclampsia. And my sincere apologies for joining late due to some unavoidable circumstances. It was excellent listening to you, Dr. Suchitra Madam. And nimige tumba ಧನ್ಯವಾದಗಳು ನಮ್ಮ ಕರ್ನಾಟಕ ಸ್ತ್ರೀರೋಗ ಮತ್ತೆ ಪ್ರಸೂತಿ ಸಂಘದ ವೆಬಿನಾರಿಗೆ ಬಂದು ನಮ್ಮನ್ನೆಲ್ಲರನ್ನು ಈ ಒಂದು ಮಹಾಮಾರಿಯ ಬಗ್ಗೆ ತಿಳಿಸಿದಕ್ಕೆ ನಮ್ಮ ಧನ್ಯವಾದಗಳು.
Thank you so much. Thank you so much.
Suchitra ma'am, your Kannada is so good.
ಇಲ್ಲ ನನ್ಗೆ ಎಷ್ಟು ಚೆನ್ನಾಗಿ ಬರಲ್ಲ, but I can understand everything.
But you can communicate so easily, flawlessly.
Manjula, there are a lot of questions.
Yes.
And and congratulatory messages and compliments.
Madam,
Yeah, Bharati, you can conduct that.
Should I
Yeah,
take
yeah.
or?
I'll start. Yes.
Okay. Start,
So once of all, Dr. Suchitra, there are a lot of compliments for you. And there is one case history which somebody has put in, a patient with 3+ proteinuria, bilateral pedal edema, but BP is normal. Her urea protein are normal, but her liver functions normal, but she's having oliguria only 26 weeks. Is this a case of capillary leak syndrome and atypical eclampsia? Should we terminate the pregnancy? Your opinion, please.
Right. I think this patient could fit into the atypical preeclampsia because she's got 3+ of proteinuria. But we just have to make one thing you have to ensure, if there is a proteinuria, is there an underlying kidney problem which could be causing this? Yes. And if there is no blood pressure, I would take opinion here of a nephrologist also. If there is no hypertension, there is no other systemic involvement, only proteinuria, probably I would wait and I wouldn't be in a rush to terminate. But yes, I would label her as a typical atypical preeclampsia, and I would continue the management with the help of a nephrologist, because sometimes a nephrotic syndrome could present this way. We should also rule out connective tissue problems at this particular time. And if, sometimes a lupus can also present, we've had an atypical lupus present exactly like this with 3+ of proteinuria with absolutely normal blood pressure. But we have to be vigilant, maybe a multidisciplinary, as I said, speak to the nephrologist as well as, a rheumatic person. And then only, if you feel that there is no response coming out of it, only then consider termination. Because otherwise the blood pressure is absolutely normal.
Yeah. Thank you, madam. I think you rightly hit on the spot, saying that we have to think about systemic diseases like lupus, which is quite common in the present scenario, and we need to evaluate that probably along with the nephrologist also and a rheumatologist. Madam, there's another question from Dr. Usharani. Madam, when does the repeat dose of magnesium sulfate is to be given? After 15 minutes or 30 minutes of a repeat convulsion?
Usually you would repeat it after 15 minutes. If you feel you've given the Maxelf and the convulsions have just immediately occurred, you can repeat the dose in 15 minutes. Absolutely no problem. But then if it is a repetitive convulsion, don't immediately repeat the dose. Wait for the Maxelf to act. Most of the times what we have seen is when you're giving the Maxelf in time, the IV dose, and then you're giving, either you're continuing it as an infusion or you're giving an intramuscular dose later. Most of the times patients, unless they've been brought into the emergency room, they're already fitting. Yes, then it takes a little time. But please do give that IV. There are problems sometimes if they've been brought to the ER, the emergency room, fitting. To take an IV line also becomes difficult. So that's why you have to have a team of people who are managing this particular patient. Because in a fitting patient, to even give it intramuscular is also difficult. So therefore, try to secure the IV line as soon as possible, give the IV dose, and then give the intramuscular dose. And
Thank you.
When people still are giving IV diazepam. So time and again we say, please, in your labor rooms or in your emergency rooms, keep enough stock of magnesium sulfate. But majority of the times what happens, it gets over and they've forgotten to, replenish the stock. So that is something busy labor rooms and busy emergency rooms must, keep a stock of.
Dr. Suchitra, madam, there's another question from Dr. Lakshmi Priya. If a patient has gestational hypertension, she started on treatment and her blood pressure is around 110/80, should we taper and continue the treatment, or should we taper and stop the antihypertensives?
I think if she's going down to 110/80, probably the dose is on the higher side. So I would reduce the dose of the labetalol or whatever antihypertensive you're using, and then try to get that, try to control that particular. 110/80 is on the lower side for a patient who's on antihypertensives. One word of caution is, when we tell patients, take this tablet, one in the morning, one in the evening. What I do now is I write the timing. So if you're giving labetalol 8 a.m. in the morning, 8 a.m. in the evening, and then check the blood pressure at 9 a.m. and 9 p.m. Many of the times what happens is 8 a.m. sometimes becomes 10 a.m. and 8 p.m. sometimes becomes 12 midnight. Once the woman has finished all her housework, then she takes the tablet. So specify the time of taking. And another thing which I'd like to mention is, supposing you find that you've given the standard dose of labetalol, oral labetalol, and you find that the BP is not coming in control. You have a 200 milligram labetalol also. Say you've given 3 times a day, or you've given 200 twice a day, then don't keep on adding labetalol. You probably then will benefit with adding nifedipine. So then titrate the two together, and most of the times with these two, your BP does come under control.
Thank you, madam. And that's a very good tip that you said, that we need to write down the time, as you said, because most women in our country try to take the tablets according to their meals. And we know that most women do not take their meals on time. So
Yes.
writing it down 8th hourly or 12th hourly is very, very important, irrespective of the timing of their meals.
Right.
I think that's a very good tip that you have given to the audience. And there are a lot of compliments again, and somebody has praised your voice. It says like soothing,
Thank you.
soothing music.
It's not as good as
Dr.
Muralidhar Pai's voice.
Suma from Mysore has praised your voice, like your voice is so soothing like a music.
And Galaxy wants to know, what are the analgesics used in eclampsia?
Usually we don't prefer NSAIDs. So we are using tramadol, we are using paracetamol, but paracetamol is also going into an NSAID group, but it's a milder variety. So we don't use the standard Jonac pessaries, which we use for normal C-section patients. We prefer to use the supridol pessaries, which is tramadol.
Yeah, tramadol. Yes.
For that.
Madam, your experiences with intercurrent eclampsia, Dr. Vanamala wants to know.
To be honest, I've seen only one case when I was a postgraduate student, and that patient, postgraduate students, I'm pretty old now. So when I was a student, and that time they talked about intercurrent eclampsia, but currently today, the guidelines don't recommend intercurrent eclampsia at all. If the patient has had convulsions, please stabilize her and deliver her. She's had severe preeclampsia. Yes, you can carry on the pregnancy till the time you shifted her to a tertiary care, or till you feel that she's stabilized and the baby is sufficiently mature, then you deliver. But intercurrent eclampsia, no. Apart from that one experience which I saw as a PG student, I haven't seen at all.
Thank you, madam. There are just 2 more questions. I hope time permits, we can take them also.
Yes, ma'am. Yes, ma'am.
Dr. Indira Shivanand wants your opinion on the newer anticonvulsants, that is levocetiram in pregnancy.
Levocetiram, they are doing tests, but when you have a trial which is as huge as the collaborative eclampsia trial, which is an RCT done in so many different countries, we cannot reach that particular nature of an RCT. So unless we get a good enough trial to say that that is better, I know that there are the sample size is very small. So I still would consider using only Maxelf. Yes, there are times when you have to use phenytoin, that is diphenyl hydrantoin. If the patient has developed a Maxelf toxicity and you still need to use something, yes, in those cases we can. But otherwise, no, we right now don't have. But there are lots of newer antihypertensive drugs which are coming into the market. But honestly, they're not even reaching up to the category C. Whereas the one which I mentioned to you, nicardipine, that we found as a very useful drug. It used to be only with the cardiologist, but that drug is a useful drug available for oral as well as IV use. And the headache or the the hypertension is better, or in fact, when I say better, it's lesser as compared to nifedipine.
Thank you, madam. Dr. Usha Rani wants to know the dosage of aspirin, whether it's 75 or 150 milligrams.
Fantastic question. Well, the aspirin would always say 150 because that is a minimal dose which is required to control the changes or the secondary trophoblastic permeation which is lacking. That is a minimal dose that is required to reverse those changes. So aspirin recommends 150, and they talk about giving it only at night, that is 8 p.m., 9 p.m. after the woman has eaten, never on a fasting stomach. We have talked about 75 in our gestosis score because remember, the patient was not investigated. She's come for the first visit, only the gestosis score, where we are looking at the high risk factors. This patient probably may never reach the, the complicated sonography. So she may not be able to afford that. She may never come back to you. So that time we talk about the 75 milligrams dose, but again, at the same time. Many a times when women are taking low dose aspirin, they're worried about, because this drug is used mostly for older people with cardiac problems. You have to counsel them. And if you're using a 150 dose, we usually stop at 37 weeks. And if the patients are taking it, remember, if she goes into a premature labor, please tell the anesthetist that you've given it, because they might want to, you might want to do an APTT and check what is a PTT and APTT at that particular time. But otherwise, 75 dose, if I found that, the Dopplers are all fine, but only the PAP-A values are less than 0.5 mmol, and this patient is at a risk for developing an FGR, but not preeclampsia, then I would look at a 75 milligrams dose.
Thank you, madam. And Dr. Selvi wants to know whether the pregnancy can be continued after the magnesium sulfate has been given and her imminent symptoms have been controlled and blood pressure is under control.
Yes. In a case of severe preeclampsia, if she's well controlled, but if she is well controlled and you want to keep her in your place, or you want to buy time to shift her to a tertiary care, is what you need to decide. So if she's well controlled, shift her to a tertiary care. And if you feel she's 25, 26, 27 weeks, try to investigate and find out what was the cause of that severity and then decide about the delivery. But we cannot take them to term, probably 34 weeks, 33 weeks, 34 weeks, or till you've shifted her to a tertiary care. The severe preeclampsia, the whole time, they're probably on higher doses of antihypertensives. So you can't keep on pulling the thread for too long. And meanwhile, do investigate for antiphospholipid antibody syndrome, because those are the ones which can suddenly, catch you unawares, and you may have an abruption and may even lose, that particular baby.
So it's like sitting on a volcano.
Absolutely.
You have to be very careful.
Very careful, very careful.
Yeah. And Dr. Lata Shukla tells us, madam, that you're a very good singer and orator. So hopefully the next session we have with you, we will start off with your singing first.
We will have Muralidhar Pai leading the show, and I can
We can have an Antakshari.
Yeah, we can have an Antakshari, absolutely.
Madam, your questions are moving. I mean, you are getting lots of questions again and again. Like,
Madam, is it okay? Can we take the questions? Or
yes, you can. You can.
Well, Deepashri Patil wants to know whether we can give low molecular weight heparin and aspirin together in patients with both bad obstetric history and history of preeclampsia.
Yeah.
In the prevention in the present pregnancy.
Well, I would give low dose aspirin if it is proven by the thrombophilia profile that it is positive, or if she's got a previous history of a DVT or an abruption which is remote from term, and if she's got a family history of DVT, or she says that somebody's got stroke at a very young age. Those are the patients where I would consider low molecular weight heparin, but documented is always better to take. In a bad obstetric history, the same rule applies. So low dose aspirin plus low molecular weight heparin, both can be given together. But remember, this is an expensive drug. For the low resource settings, to give that for a longer period of time is not exactly easy. So give it for a stipulated period of time and decide when you have to deliver her optimally. You may not wait till 38 weeks. You probably want to deliver her a little more earlier. And there again, strict monitoring of the fetus is very essential, because these again can go into an FGR.
Madam, in the low resource settings, you said,
Yes.
of course, we know that low molecular weight heparin is quite difficult to prescribe. And but I have used in my practice unfractionated heparin in the previous years without much any of impact on any complications. So what is your take on that?
Well, there was a time when we also used unfractionated heparin, particularly when we were at the medical college setup, because it was not possible. One
Yes.
was not available. The only thing is you have to keep titrating. You have to keep monitoring the dose, and you're always worried about the paradoxical thrombosis that can occur. Of course, that is not so common, but then when you're giving it the unfractionated heparin, it's pain-wise it is the same subcutaneous dose again. But you have to keep titrating the dose that protein sulfate ready. If you're doing it correctly, no harm. But then, you know, sometimes you feel, why not give her that low, you know, the low molecular weight heparin? It's so much more easier to give it. You don't have to worry about monitoring and take it herself. You know, we teach our patients to take it themselves, take it on alternate thighs. Sometimes I think that in the long run, if you have to give it, probably that is better. But NWH does not prevent preeclampsia.
Yes. Thank you, madam. And I think this is the last question we'll take. There's a Gravida 2 Para 1 previous normal delivery. She is 13 weeks with 1+ proteinuria, renal function, LFT normal. She's on labetalol 200 milligrams, but her diastolic is on and off 106. And she's asymptomatic, and her systolic is 140 to 130. So how should we go ahead?
So I think in this particular case, the dose of labetalol needs to be stepped. Correct time. Whatever you're giving, just ensure that the patient is taking it at the right time. And the measurement of the blood pressure is important. Now,
She's taking it
this concept.
200 mg TID.
She's having to, no, then in this case, you must add on
nifedipine.
We should add on nifedipine to that. You can titrate the dose again, 8 o'clock, 9 o'clock. 8 o'clock, if you're giving labetalol, then give 9 o'clock nifedipine. But that BP monitoring is important. So admit her for a day or 2 days and, you know, try to get that blood pressure under control. We have this concept of daycare. I'm sure it is available everywhere. The patient comes in, she's there the entire day, and evening she goes back home and then comes back the next day for the monitoring, so that, you know, you are not worried and she's not worried.
Yeah.
It can be done, you know, because when they do home monitoring, sometimes the calibrated devices, you're not very sure. They'll say, BP was all okay, but actually the BP is not okay. So calibration is very, very, very essential in these cases.
A very interesting question. Why only patellar reflex and why not any other reflexes?
Well, patellar reflex is the standard. Yes, absolutely. It's the standard reflex which you normally do, but you check ankle chronos also. That's why I said, if you can't elicit patellar reflex, it's the easiest to elicit.
Yes, it's the easiest.
Supinator, you can do the supinator, biceps, triceps. Those also can be done. But if a patient, and remember, even for that patellar reflex, you have to let that leg, that knee hang loose. If she keeps it very tight, you know, you can't really do it very well.
Yeah, it has to hang loose.
It has to hang loose, absolutely.
Dr. Suchitra, madam, I think we've had an excellent interaction along with your excellent lecture. We're extremely thankful to you. And of course, there are a lot of appreciative messages, which I have not read out. And I now hand over the screen to Dr. Manjula Patil and Dr. Muralidhar Pai.
Can I just say something? Can I just say something?
Madam, please.
I definitely would like to thank Dr. Muralidhar, because it's nice to come to you know, an audience where they're receptive. You know, you are spending, and it's a good academic exchange, and I really appreciate the efforts taken by KSOGA to promote this, you know, CPAP. That's what it's called. And if I mean, can I make an appeal if it's okay with you all?
Sure, madam.
Yes, ma'am.
I'm contesting for the post of Foxy representative to FIGO. So, Yellargu, please, namge vote kodi. Namge nomination kodi. I need it desperately.
So
Madam,
cute.
I have an appeal here too for you.
Yes.
Madam, I am putting in my nominations for the Family Welfare Committee. So on behalf of KSOGA and myself, I earnestly request you and sincerely, nimge vote kelta idini, nimma
From
vote.
KSOG, we have sent your nominations.
See, my thumb has come up.
Thank you, madam. Thank you. My thumb's also there.
Ma'am, Dr. Krishna from Bangalore and Dr. Shobha Dhananjaya from Davangere and Dr. Dhoni Mat from Hubli have given you appreciated your talk, and many compliments from many more, and so many questions in this program has shown that the impact of your talk and the topic itself. And I congratulate Dr. Muralidhar sir for giving such a wonderful speaker on this platform. Now, my earnest request to Dr. Muralidhar sir to give the expert comment on this program.
Well, when the expert has spoken, there is nothing to give expert comment on that. I really thoroughly enjoyed, I can say. Suchitra madam has been a very, teacherly figure for me since so many years. I know her since so many years. She has visited Manipal also. And today's lecture was just a masterpiece. That's all I would like to say.
Very true.
And as you correctly pointed out, the amount of questions that have interactions that have come up after the
Very
talk
true.
shows that people were very intently, they were listening and they were trying to
Very true.
understand, and they got all the latest as well as the old, both they got. And I think that's all I would like to say.
And the
Thank you once
attendance
again,
was
Dr.
120.
Yeah. So thank you once again, Dr. Suchitra, for accepting this. In fact, as you said, there was we had to exchange, and I just asked you 3 days, last week, I think, and then it was all done. So thank you very much once again. And Manjula, you may now hand over to
Thank you,
Dr.
Murli
Durga
sir,
Das.
for that wonderful speaker on this platform. Now, I would like to request our treasurer, Dr. Durga Das sir, to give the vote of thanks. Durga Das sir?
Is he here?
If he is
Otherwise, you
not
can.
there.
Otherwise, you can conclude.
It was a very wonderful program on this platform with such a good and interactive audience for this topic. So I thank KCOG and KSOGA for giving such a wonderful session, webinar on this topic. I thank Murli sir and Hema ma'am, Vidya Bhatt ma'am. I thank our patron MG sir, President Sajjan sir, Secretary Dr. Bharti Rajshekar and Dr. Durga Das sir, and whole admin team of KSOGA and all the EC members and all the delegates for attending this program. And thank you so much, Dr. Suchitra ma'am, for making this a very grand success. And I thank one and all for making this a grand success, and take care. Good night.
Thank you, Manjula.
Next KCOG will be on March 3rd.
Yes.
So that it is usually on the first Thursday of every
Thank
month.
you.
So
First
we'll
Thursday.
come up with one more topic. So thank you. Till then, bye for all.
Thank you, sir. Thank you,
Please.
Suchitra madam. Thank you,
Thank
Dr.
you,
Murli
thank
Desai.
you.
Thank you so
very
much, ma'am. It was a wonderful session.
I enjoyed it.
Bharti ma'am, good luck. Nam
Thank you.
kadinda
We always
continue.
support, all of you need to support me, Pan India.
We
Yes.
have sent the nominations from BSOG.
Thank you, Manjula. Thank you very much.
Thank you.
Namaste.
Thank you all. Take care. Good night.
Namaste. Good night.